Hello, good afternoon, everyone, and very warm welcome to all of you present here. I am Shifa Sheikh from Docplexis. As we all know, Docplexis is one of the India's most trusted and first leading digital platform dedicated exclusively for doctors, focused on enabling continuous medical education and professional networking. So, dear users, we are very excited to inform you that we have launched a new and updated version of Docplexis application with more enhanced features. So, you can download easily Docplexis application from Google Play Store and App Store and keep yourself updated with latest notifications, see important CME session, and learning opportunity at all your fingertips. So download the application today for smoother and enhanced learning experience. So viewers, today I would like to welcome for another very interesting session on very important topic on Docplexis platform. On main topic, clinicians' role in early detection of public health emergencies. As you might be aware, clinicians are often the first to recognize unusual disease pattern that may signal an emerging public health emergency. Early identification, prompt reporting, and timely coordination with public health authorities are essential to containing outbreak and minimizing their impact. Strengthening clinicians' ability to detect a typical presentation, interpret evolving epidemiological trend, and respond through established surveillance system is critical to improve and protecting population of the health. So for this very interesting session, it's my absolute pleasure to once again introduce our esteemed speaker for today's session, Dr. Amitav Banerjee. Dr. Banerjee served in the Indian Armed Force from 1978 to 2005, and he started working as professor and subsequently as the head of the Department of Community Medicines at Dr. D.Y. Patil Medical College, Pune. Dr. Banerjee has published over 100 papers in national and international journals and has undertaken several funded research projects. He has also delivered several keynotes addressing at national and international conferences. So, without further delay, I would like to hand over the session to Dr. Banerjee. Over to you, sir.
Thank you, Sifa, and it's always a pleasure to come on the DocPlexis platform and share my views. So today I would be talking about an important issue because nowadays the clinical practice, particularly, is becoming more or less automated with large number of investigations, large number of use of AI is also coming in a big way, and the patient physician contact may not be that insightful as it was earlier. History taking, occupation, exposures. So, in that context, our country have faced a lot of challenges, disease outbreaks, both communicable and also non-communicable, or sometimes common source exposures. We had waterborne outbreaks. Then there may be certain industrial toxins. So today I'll be just presenting certain examples, historical examples, which will give the methods which clinicians should retain some contact with the patient, some background, where they will be in a position to find something unusual happening in the community because they are the first contact. It is something like FIR in a police station. The patient first reports to a clinician, and many a times the patient will come one at a time. A common pattern may be missed if the clinician is not astute or open to pattern recognition, open to something unusual. So some points from history. So I will be sharing some slides which will illustrate the. So it is just to give an idea of how to go about when there is a common source outbreak. So these are some of the clinicians' role in early detection of public health emergencies. It may be a communicable disease emergency, or it may be a waterborne exposure. So from unusual bedside observations to population level public health. And here there is sometimes a gap. A clinician and the people who are in charge of controlling the emergencies, they may be a gap in information flow, if there is a delay in recognizing pattern, and that is the most crucial time. That crucial time, if it is that opportunity is lost, the outbreak or the public health disaster may continue, and there may be large number of preventable harms to people, either to toxic exposure or spread of communicable disease. So clinical vigilance often provides the first signal that something isn't right. It is something like each clinician with practice and with experience, they also have something, a pattern recognition, just like nowadays we talk of AI recognizing pattern. So clinicians also have a inbuilt intuition, judgment, and that is why clinicians can form an early warning system. Astute clinicians recognize patterns that do not fit expected disease presentation. We'll give some from history, and we should be open to any emerging disease or emerging conditions. They cannot, they connect unusual cases, question initial diagnosis, and raise concerns early. It is better to err on the side of safety rather than ignore any unusual things. Sometimes there is pressure also. Sometimes there is a pressure to hide things. So sometimes courage is also required. Courage of conviction, moral courage to speak out, to question. You may be wrong, but if you are miss something, lives will be lost. Prompt reporting can trigger epidemiological investigation, lab testing, infection control, and policy action. The role extends beyond infection outbreak to environmental and nutritional hazards. Sometimes there will be toxin in food. We have got issues of adulteration. Sometimes there may be environmental hazards, environmental pollution, water pollution, air pollution. We had Bhopal gas tragedy. So these are unusual things. So these are some of the historical example landmark. As you know, HIV/AIDS emerged somewhere in the 1980s, and how identified by clinician. There's a paper, I'll give the references in the end. Gottlieb and colleagues reported Pneumocystis carinii pneumonia in previously healthy young men, prompting investigation of a new epidemic. And that's how AIDS was identified. If you know, we always go by basic in the distribution of disease, person, place, time. So if healthy young men are having Pneumocystis carinii, which is in older people, immunocompromised, malnourished. This is something unusual. Besides that, some of the young men had candidiasis also. Some had Kaposi sarcoma. These are very unusual in a young people, and also the time. Within a very few months, they observed clinicians that number of clustering is there, and then they found that these people, they took the history and sexual orientation. They were either gay people, gay men, and then there were reports of certain blood-borne similar syndrome, like people who have repeated blood transfusion. So they could get a clue that this is something, some agent is blood-borne. And then the famous tennis player also got infected that time, Arthur Ashe. So they could started looking for the agent in the blood and body fluids, and they identified the HIV virus. So this was the initial, was just like a police panchnama, and then the higher the you get the clues and they you connect the dots. So this was an important year, because by the 1980s the epidemiological methods were well established, and the definitive agent could be identified in record time almost. Then in 2003, before that, I think in 2003 was the SARS one. SARS one, if you remember, this recently we had the SARS two. SARS one outbreak was somewhere in Southeast Asia, China, and these first cases were identified in Vietnam, in Hanoi, capital. Small hospital, primary private hospital, 60-bedded hospital. Some cases, I think it was a Chinese person who had come there. He had unusual pneumonia and severe type, and doctors there alerted the WHO. WHO sent infectious disease expert Carlo Urbani to Hanoi, and he started investigating with some health workers. And he identified something unusual is happening was a large cluster of cases, and he instituted the infection control measures and then the identification of SARS-1 and the prompt identification of an unusual outbreak limited its spread. Of course, the case fatality was quite high, more than 20%, unlike the present one where the case fatality was very low. So that is one example, historical Carlo Urbani. And unfortunately, Carlo Urbani also contracted the infection. He isolated himself, but he was on ventilator for quite some time. But on his way to Bangkok, he felt sick, and when he reached Bangkok, he isolated himself in a hospital, but he succumbed. He unfortunate thing. That is Carlo Urbani. Then we have this uh, COVID-19, again recent one. Here also there was a brave physician who first identified a Chinese ophthalmologist, Wenliang, and other clinicians. They identified something very unusual in Wuhan. They found patients, and because he is an ophthalmologist, he was in close contact, and he tried to inform his colleagues. And China is quite authoritarian. So initially they wanted to hide something, and he was admonished, he was given a warning that you are spreading rumors. But ultimately it was identified, and then Li Wenliang, he also contacted the infection. He isolated himself in a hotel. He told his family not to visit him, but his parents visited him. They contacted, but they survived. Unfortunately, he succumbed. Li Wenliang, the Chinese ophthalmologist, at a very young age, 33 years of age, he was survived by his wife, son, and a pregnant wife. So unfortunately, he died. And then subsequently, the Chinese government honored him. So initially, they admonished him. So this is a history of 2019. And this is the then Ebola, of course, now another outbreak is going on. So these again syndrome complex. 2014 was the onset of the largest outbreak. More than 11,000 cases were there. And before that also there are number of outbreaks. So that is something which spreads something like HIV/AIDS. So they could identify the epidemiology, and if they could, if today also, if they could enforce infection control, universal precautions, then they have these other Ebola. The other problems are the rituals. The dead bodies, they handle it very intimately to pay homage, kissing and other things. And dead body, because it's a hemorrhagic fever, they may be, besides that, they are GIT infection, they may be vomiting. The body may be having high viral load with the blood over the body, hemorrhagic. And the infection spreads from the rituals of funeral rites. And of course, they eat the fruit bat. They hunt, poverty is there. Then their hospitals are not very well equipped for universal precautions. So this is the one of the problems of Ebola there. Presently also the outbreak is ongoing. So these were identified. Then Legionnaires' disease is very interesting. It was, of course, should have discussed it earlier. 1976, they identified some convocation was going on in America. A large number of delegates were staying in some hotels, and in that, those who were staying in that hotels, they all got some atypical pneumonia, and there were clustering of cases. And this was the first time they could identify a new. I mean, this was the first time of they identified Legionnaire's disease, which is due to Legionella pneumophila. They identified a new organism which was found in the air conditioning systems, water and other things. Say it is now identified from water coolers, and it is found in water of closed air conditioning systems, showers, baths, and other things. So this was again, there were more than 200 cases, and I think about 30 odd deaths also occurred. Then hantavirus was identified again in 1993 in Four Corners region of USA. Again, they could identify not the, of course, now recently we had a big news of the hantavirus on the ship. So, but this was identified much earlier, and there are more hantavirus cases on land than at sea. So, this was, I think, reaction of current media. But hantavirus exists, and it was identified Four Corners region. It causes the respiratory problems in the strains which are found in the Western countries. Hantavirus is found also in our country, where it causes a renal syndrome, renal failure more commonly, renal and hemorrhage. And in the Western countries, it causes the pulmonary syndrome. So hantavirus, again, common history of exposure to rodent, some deer, mouse, excreta of rodents and other things. So these clinicians can help in when they get some unusual cases. They recognize the pattern. They have to ask of the history. They have to see the household. In our country, people are living in, say, slums. People are living in overcrowded conditions. People are migrants. So if you can ask the history, the traditional clinical medicine we had, family history, housing conditions, sanitation. Sometimes, in some cases, when something is unusual, it gives a clue. That's why I said it's very important to retain some of those skills, at least minimum checklist. Occupation, certain housing, exposure to some common festivals, mass poisoning, and of course, water supply is there. Then, of course, 1970, the toxic shock syndrome. It was. I'm just giving a overview. I will be giving the references to the paper, so you can read at your leisure. Young women were coming with fever, high fever, toxic shock, and it was isolated to the streptococci in tampons. Then newer hazards like EVALI 2019, emergency physicians and pulmonologists, they identified the lung injuries, and it was traced to vaping. It was traced to vaping. That is the vaping is coming up in a big way. So again, that's why you should know what is the Gen Z doing nowadays. They have it's. I mean, it's not only political intelligence, even for health intelligence. What are the habits, vaping and other things, and what were the lessons from all these clinical astute clinicians who could raise the signal? It was not one isolated patient. It was an unassociated pattern, multiple. That's why they say syndrome identification. The clinician is the first contact where any unusual pattern or syndrome can be. Then this public health consequences, the clinical reports prompted targeted investigation. Like in the gay people are having this immune deficiency, pneumocystis carindica. So they, and then some from blood donor, blood recipients. So there was some that yes, targeted investigation can be examine the blood, examine the body fluids, and other population level. So so these are the clinicians have to develop. They recognize any unusual pattern. Yes, then we cannot dismiss. And you see, nowadays there are other issues also, like the new vaccines are coming, new drugs are coming. So initially, say rare events are there. Vaccination is a rare side effect is very rare. That's why clinician may miss it. 1 in 800 doesn't see. But if you're aware of, your colleagues are also reporting that. So that should raise a signal. Why so many colleagues are reporting some unusual, some new drug is there, some new analgesic is there, which has occurred in the past. Many nebulicide it has occurred. It may occur with vaccine. So we should not dismiss it. Ki nahi, nahi, it is not associated with rare, because rare events are you are very likely to miss the rare events. Question: reconsider diagnosis. We do not fit your presentation. Report, escalate the colleagues, report to the public health authorities, infection control team, and public health authorities. Persist, continue raising concerns despite uncertainty or skepticism. We will give an example of a very brave pediatrician, young pediatrician in USA. There was a lead poisoning, and it was traced to water source in a modern day USA. Uh, and large number of children were exposed, thousands of children, pregnant mothers already exposed. And she had to fight a battle, legal battle. Public health authorities disown any association. So she had to persist, continue raising concern despite uncertainty or skepticism. Collaborate, work with other people, your colleagues, epidemiologists, lab, and if there is something unusual, public health researchers. So this is the one I was talking about, the Flint water crisis. You can just Google it and you will find a lot of reports in Wikipedia, and still some litigations are continuing. Many people have been exposed, particularly children have been exposed. So there was a pediatrician, Mona Hanna-Attisha. She was getting lot of children with anemia, young children, pain abdomen anemia, some with a blue line. So then RBC count was there. There was a stippling of blood cells, RBC. So all the signs of lead poisoning. And she analyzed the lead levels also, the high lead levels in the blood. So that was as recent as 2014. Imagine, this was in Flint, Michigan. So lead exposure, Flint, and then she intimated the authorities. The authorities denied anything. They said water is safe. It continued for quite some time. Her team compared children blood levels, and then she identified that the water source was changed to a river, Flint River, which was having a lot of corrosives in the water because of industrial effluent. And that corrosives were the lead, the pipes were corroding, and lead, old pipes were there, and lead was being leached and going in the water supply. So state official challenged it, but she persisted. The lawyers also came into the picture. Evidence of lead leaching from aging pipes. It's a very long and very fascinating story, and she has written a book also on it. I'll just show some screenshot. So this was a clinician who raised the signals, and by the time people could act, the authorities admitted large number of children had already been exposed to lead, and lead affects the IQ and brain development. You see, you don't know what future president we may have in the USA from this cohort. As it is, we are having so much problem with the instability all over the world. So this is one example. She's written a book. I'll be giving the references. Population data can uncover chronic environmental exposure. And Flint example is very important because concern rose from health of children being seen in practice. So this was in practice. Then epidemiological, you see large number. There was a geographical clustering wherever the water was supplied from these lead pipes from a particular source, like John Snow did long back. So that was a geographical year. Then collaboration with other activists, persistence, broader implication, because it can become then surveillance principle, bedside observation, and it can become very difficult. So clinicians have to fight sometimes with the public health authorities because they try to save their skin because there's accountability. So this can be one of the gaps in jumping from clinical to public health action. There is a denial, overall denial. Any new product also, nowadays the pharma industry also have got strong lobbies. So they try to suppress any adverse events. So it requires a lot of courage. It's not an easy job at times. And another very important, which you are having, 90% of us are having iodized salt. So there's a very fascinating history behind this. It was started in Ballabgarh, which is a rural field practice area of AIMS, New Delhi. Long back it started during Indira Gandhi's rule. So large number of patients in this rural health center under the Department of Community Medicine of AIMS, New Delhi. And Dr. Chandrakant Panda was the professor and head that time. So they could just seeing the clinical cases and they were finding that they are coming from that particular belt, which maybe, and the clusters, 1960s, clinicians and community have repeatedly observed higher goiter prevalence, iodine deficiency among children and women. The recurring pattern suggested iron deficiency rather than isolated cases. Because, and in fact, I remember when I was in that time, 60s, I was in school and I used to go to Dehradun, my ancestral house, father. And I used to see in the platforms large number of people coming with goiter, and they will be asking for some money or something. A large number. Nowadays, you don't see on this platform. Systemic epidemiology surveys confirmed iodine has a significant regional public health problem. The work supported broader surveillance and salt iodization policies contributing to nationwide salt iodization. And you see, the iodine deficiency in pregnancy causes cretinism, and it may cause. And the person who was responsible for this is Dr. Chandrakant Pandav. He convinced the Prime Minister then, Indira Gandhi, and salt iodization. He is known as the iodine man of India, and few years back he got the Padma Shri also. Of course, now there are other reports. I mean, that also requires, again, clinicians should be. There are other reports that universal salt iodization is causing some thyroid issues, hypothyroid. So then again, there is a scope for clinicians to confirm this or rebut this. So these are some of the reports we are getting. So these are, just to sum it up, acute infections that SARS or any, I mean, these are in the past, this is history. This is now accepted knowledge. One should be alive with the same uh, approach which the people had to identify for future. Yeah. Rapidly changing clinical picture. Early warning may trigger urgent containment. Time to report is critical. This time, the gap between the clinician and the public health authorities is very crucial. Then there may be certain chronic like lead exposure in water, and as you know, water supply is a challenge still. Recurring pattern, validation requires population, finding can drive long-term policy like iodization of salt. Again, that also intervention now, some sections there are reports which has to be confirmed. So this is the flow down, unusual clinical observation, pattern recognition, report escalation, epidemiology and lab validations like that pediatrician, Dr. Mona, she went for the blood lead levels, lab confirmation. And then surveillance system and lab testing are essential. But the clinician has to identify it. It's not which test to do, who to take samples from, which environment to study. So for that, you require connecting the dots. So these are the takeaway. Clinical vigilance is core component of public health surveillance. Pattern across patients matter more than isolated cases. Early escalation and multidisciplinary collaboration convert observation into action. Clinician-led detection applies to infectious disease, toxic exposure, and chronic nutritional ill. Persistence is often necessary when the signal is uncertain. Very hazy signals you will get, or the large numbers it may get submerged, say adverse events of any intervention. Ultimate value of astute observation is its ability to trigger population level prevention and action. I will give some of the people, martyrs, one can say. This is Dr. Carlo Urbani, who investigated SARS. He was sent from the team at WHO team, and he went to Vietnam, investigated. Then on the way to Bangkok, he he became symptomatic. He was treating and he was investigating the outbreak in that hospital in the capital of Vietnam, Hanoi, 60-bed hospital. And he got infected and symptomatic in Bangkok, and he succumbed to the infection. So this is one of the Hospital of Hanoi, private hospital, 60 beds, contacted the Hanoi office of the WHO. Patient presented. So this one patient that come, and Dr. Carlo Urbani, specialist infectious disease, answered the call. In a matter of weeks, he and 5 other health professionals would be with him. 5 other health workers also succumbed. So this is some of the hazard initially, because people are not aware of the contagiousness or the virulence of the EM. This is about the Chinese ophthalmologist who was admonished by the Chinese authorities for early reporting of unusual things. See, this is what when there is sometimes authorities want to suppress. Something fishy was happening there. Now we know, because whether it is lab leak or something, it may perhaps the Chinese authorities were trying to suppress the lab leak. Maybe that why he was warned not to spread misinformation. But he, as an ophthalmologist, he noticed something unusual. Large number of people are getting some peculiar pneumonia. He sent messages to his colleagues, and he was censored that time. Subsequently, he was honored almost posthumously. He died very young, 33 years of age, leaving a pregnant wife and a child. So this is an unfortunate thing. This is the lady, the young lady pediatrician, Dr. Mona Hanna-Attisha, who spearheaded efforts to publicize and address the water crisis in Flint. This is very fascinating. I would request all of you to do this Google search. You will get a lot of reports on this. 10,000 children and pregnant mothers already exposed to lead, and that is irreversible harm. See how dangerous it can be. And the public health authorities were challenging her uh, reports, saying that this is nothing wrong with it. So this is an important lessons, and she has written a book also on this. What the eyes don't see. That's why I wanted to show this book, because if you remember, I remember at least Hutchison's methods. They say the mind does not see what the eyes do not know. But nowadays, we have to be beyond this. We have to see what the mind does not know, what the eyes don't see. This is the trap we fall in. The eye does not see what the mind does not know, because we follow deductive knowledge from textbook. We have to see new information, that is inductive. So in that, the eyes has to see what you have not learned earlier. So then only you will identify emerging disease. I think that's all. These are the important references. I have just given few. There are many. There are many. You see, right from German measles in 1950s, it was a very mild disease, but there was a astute clinician like Norman Gregg, who identified a lot of newborns are having a congenital cataract. And then when he linked it with the first trimester, there was a rubella outbreak few months back in that Australian state. So then first trimester. So that there are many like that. So there is a very close link between clinical medicine and epidemiology and public health. Unfortunately, with specialization, even among clinical medicine, people are getting compartmentalized. So probably we may miss many such clues. So that's why I thought I tried it, because it's a very scattered subject, but I just tried to give some examples. So this is Gottlieb about AIDS. Second is about the SARS. Third is about the Chinese Li Biling, SARS present outbreak. Then fourth reference is about the Ebola. Fifth is about the Legionella. This is again interesting. You should read it. And then Hunter virus, number 6, when it was first identified. Then this is toxic shock syndrome in young girls, menstruating girls. Then number 8 is vaping, Gen Z. Then number 9 is very interesting. Again, this is the Flint water crisis. In fact, this used to be my favorite question to my students, which I used to give the scenario. I said, guess which country is having this. Nobody guessed it could happen in America. I used to tell them in my office only, go and see Google search. They were very surprised कि अमेरिका में भी ऐसा हो रहा है. मतलब सब जगह सब कुछ हो सकता है. Nothing is above board. We think drinking water is very safe abroad. Anything can happen anywhere. Murphy's law. If anything can go wrong, it can go wrong. Number 10 is on iodine deficiency. We have the iodine man of India, Dr. Chandrakant Pandav. He has spent his life on this. So that's all. I think I can stop sharing the screen. If you have got any questions, I can take.
Yeah, so thank you so much, sir, for your wonderful explanation on such an important topic. So I have a few questions from our audience, sir. Can I go ahead and can I read it off for you?
Yeah, yeah, please.
So you almost answer everything. We have only two questions. So in your, I just wanted to ask, sir, in your experience, what are the biggest challenges clinicians face to recognize and reporting unusual disease pattern?
That's a good question. As I give some examples, like I gave the China example, where the doctor identified, shared with his colleagues, but the authorities warned him not to spread. So this is most clinicians face this. Sometimes, suppose there is some hospital infection outbreak, so most of the hospital administrators or managers or the would not like it may bring a bad name to the hospital. So this is one of the challenge. But one should always, the clinician should see the patient should come first. There should be no harm to other patients. So these are one of the challenge. Second is now with the change in practice, clinical medicine is becoming more automated now, more investigations, there is less time with the patient. So we have to keep in mind at least some basic questions we should doctors should ask to the patient, and particularly if he or she is seeing a large number of unique cases or even well known cases, but there is a large number in a short time, so something unusual is happening. Then some times, so if we are busy here, that is the one challenge is the challenge of time, challenge of documentation, challenge of technology, because technology can take away from interaction with the patient. And so these are some of the challenges.
Yes. Thank you, sir. And the next question I would like to ask. So, what are the clinical red flags should prompt physician to suspect an emergency public health threat rather than isolated case?
Even suppose even one isolated case, if it is very unusual or very typical, suppose if you, it's a certain which can be a say source of some like we had recently, which ultimately came out to be a poisoning case, like tarbuja in Bombay. It happened that one family died, whole family died. That is something unusual because all family cannot die, so that is unusual, but we have to be on the safer side whether it is a mass kill. Then recently, one girl died after a haldi ceremony in, I think, Madhya Pradesh, Indore. So and some other. So this type of unusual thing, there is a history of some haldi ceremony. Then one has to have some awareness that haldi can be contaminated with, say, some chemical like methanol, or some people may be allergic, or large number like we had last year, I think last year or I think couple of years ago, large number of Guillain-Barré syndrome in Pune. So this is something unusual. There is a mapping. Guillain-Barré occurs. It's a rare condition, but we had Guillain-Barré. It was suspected to be from a water source, where Campylobacteria jejuni has been associated with Guillain-Barré, but again not in such large number. Then that year, Pune also had outbreaks of Zika, dengue, chikungunya. So Zika has been so it's not very the picture is not very clear. So these are unusual things. Sometimes you may identify the cause, but you have to alert the authorities. So either presentation may be unique or the time. In a short time, similar cases coming. Or third is the geographical location. All cases are coming. So that means these are pointers. Something unusual is happening.
Yes, sir. That's the question, sir, which we received from our audience, and you answer in very detailed manner. So, thank you so much, sir. As we conclude today's session, on behalf of entire Docplexis team, I would like to thank Dr. Amitav Banerjee for sharing your valuable and clinical practical experience during today's session on clinicians' role in early detection of public health emergencies. So, and we also like to extend our sincere thanks to all our participants today for joining us and for your active participation throughout the session. And we hope you found this discussion very informative and clinically relevant in your clinical practice. So on behalf of DocPlexis, we really thanks once again for being a part of our educational initiative, and we look forward to welcoming you all for our upcoming educational webinar and support during your learning journeys. So thank you so much, Dr. Amitav Banerjee. We are looking for many more collaborations with you in future as well, sir.
Thank you, Sifa. Thank you. It's a pleasure.